My talk will be on the indications for fusion in lumbar degenerative diseases. So this is not, there is no easy answer to that question. I will give you some details. How can we decide a lumbar fusion surgery? In general, saying that there are indications like lumbar degenerative listhesis, lumbar degenerative deformity, that may be a kyphotic or scoliotic deformity, and iatrogenic instability after extensive decompression for lumbar spinal stenosis. Those cases may need a fusion surgery. If we look at the concept of motion segment is a combination of two facet joints and one disc. And that motion segment starts to get degeneration from the disc, then the facet joints, and the body tries to correct it. And there is a natural course of degeneration, which was described by Kirkcaldy and Willis in 1970. The first phase is the dysfunctional phase, then an unstable phase, and stabilization phase. In fact, during the unstable phase, we may need some fusion surgery. So this is the progression of degeneration by the time. Starts with dysfunctional phase, unstable, then rest stabilization. If it is rest stabilized, then we may need less fusion surgeries, just a decompressive surgery, and if it is possible, without causing any iatrogenic instability. On the left, you will see normal mobile segment. On the right, a degenerated mobile segment, which is the disc height is decreased, ligaments are relaxed, and facets joints are overloaded. So in stenotic patients, there is a soft stenosis phase, which comes mostly from the disc herniation, partial disc herniation, and then the subluxation and a dynamic stenosis, and then a hard stenosis because of hypertrophy of facets and ligamentum flavum. So the surgical techniques for lumbar spinal stenosis are decompressive surgeries and decompression and fusion surgeries. In the past, we used to do total laminectomies, then we switched to the fenestrations, then we switched to doing a unilateral approach and bilateral decompressive surgeries to protect ligaments, facet, and avoid instability. So microsurgery or tube-guided surgery may need to that aim of unilateral approach and bilateral decompression. This is also my practice. I have started with endoscope, then switched to microscope, and working and making, as you see in this case, two-level decompressions. The above axial images are before and then after surgery, even for 4 levels, like you see from L1-2 to L4-5, with 4 small incisions. And you see on the left before surgery and on the right after surgery decompressions. Then, when fusion is necessary, if you create iatrogenic instability, somebody says it is after extensive facet resection and or 3 levels total laminectomy, degenerative listhesis plus back pain, degenerative scolia plus back pain, and flat back syndrome or lumbar kyphosis. So there is so-called spinal complex lumbar spinal stenosis, the term, which has such features like you see here. This is a typical case of a lady with flat back syndrome. Even in the direct films, you can see a kyphotic lumbar spine, and I recommended to make a fusion surgery for this lady. What about degenerative listhesis plus stenosis? There is still some option for decompression alone if the patient has no back pain and no movement during flexion extension films. So stable segment with osteophytes and the loss of this space and anterior listhesis less than 3 millimeters are the patients who we cannot we may not do a fusion surgery, so only decompression. But in cases with more anterior listhesis, more than 3 millimeters, mobility in dynamic films, discite preservation, sagittalization of the facet joints, and absence of osteophytes, osteoporosis, those cases may need more fusion. And what are the techniques? There are different techniques. Actually, you have heard very nice MIS fusion techniques from Richard Assaker. And what is the evidence for fusion surgery in the literature for decompression surgery versus fusion surgery? Unfortunately, we don't have much evidence that is on the side of fusion, especially in lumbar spinal stenosis patients. This study is a meta-analysis from 2015 saying that decompression plus fusion is not more effective than decompression alone. This is from 2016 from New England Journal of Medicine, the Swedish study saying that decompression plus fusion surgery did not result in better clinical outcomes at 2 years and 5 years than did decompression surgery alone. This is another study from 2018 saying that instrumentation for low grade, less than 30% degenerative listhesis, spondylolisthesis, did not result in superior outcomes. This a recommendation of WFN Spine Committee, and in that recommendations, we described that the stable spondylolisthesis patients may not need a fusion. Unstable listhesis patients with symptoms, especially back pain, may require fusion. And fusion may be advisable in patients who undergo bilateral facetectomy of more than 50% and bilateral discectomy. Especially those patients may have gone to a fusion surgery. In conclusion, unilateral approach with bilateral decompression is currently the most popular surgery for spinal stenosis. MIS techniques have significant advantages. Fusion is an option, especially when listhesis or instability are present, but indications remain controversial. So fusion indications are additional back pain, overt instability, preserved disc height, and facet degeneration. Especially having those features more than one. Better to perform with short fusions, and fusion surgery has complication rate up to 25%. If you come to the first question for lumbar degenerative listhesis, stable listhesis do not need fusion surgery. Lumbar degenerative deformity, kyphosis, fleck back, and scoliosis is a major surgery. Many factors may affect the indications, especially the age, comorbidities of the patient, the osteoporosis of the patient. Those must affect our surgical decision making. And the iatrogenic instability after extensive decompression for lumbar spinal stenosis, it may be necessary, but you can avoid it by MIS techniques. And if removal of unilateral facet, 2 to 3 laminectomy will not affect stability. Actually, we need to remove all the facet or bilateral more than 50% removal of the facets. This is what we recommend, the algorithm. If the patient has no back pain, decompression alone you may certainly choose. If the patient has back pain, and you must search for significant radiological instability. If not, facet injections, sacroiliac joint injections, brace and exercises. If no benefit, you can go to fusion. So fusion indications are in certain conditions. Thank you for listening to me, and I want to invite you to Istanbul Spine Masters in October this year.
Zileli, thank you so much for this presentation. Dear friends, if you have questions, please write on the chat part. Zileli, you have seen some cases. Show us some cases that you have done for lumbar spinal stenosis. How many levels can you do decompression with tubular guided system?
I did, as I mentioned, I did maximum 4 levels, but it's a time-consuming thing. Yeah, you may think it is taking time, but in every level, it may be 45 to 60 minutes, and 4 levels may be more than 3 hours surgery.
And what about the learning curve? Can a classic neurosurgeon can do the tubular guided system with microscope?
Yeah. As we know, it is more suitable for learning of the general neurosurgeons, because we all use microscope very, very nicely. And so that the learning curve is shorter than full endoscopic systems.
Thank you, Zileli. Oscar is asking, what is the real meaning of facet joint effusion?
This is, we must not tell that if there is just facet joint effusion, it doesn't mean there is significant instability at that level. But if it is together with some small listhesis or some other signs, it is a supporting radiologic findings supporting the instability. It is not alone. If it is alone, we cannot think it is really unstable.